Good morning, everyone. Good morning, everyone. Okay, that's better. My name is Terrell Parker. I use he, him pronouns, and I manage Max Escalate program. I'm here today to encourage President Biden to develop a national prep program, and I need, yeah, we can clap for that. But I need your help. If you attended the Biomedical Summit earlier this year, then you probably heard me tell my story. I was actively using PrEP for 2 years as a tool to live my best, most healthy sex life. After moving back to Indianapolis in 2020, I had a break in my PrEP usage. I found a new doctor who was less experienced prescribing PrEP. I went to the pharmacy to pick up a new order one day when I was told that I needed to pay nearly $3,500 because my insurance no longer covered my PrEP. Over the next 90 days, my doctor submitted 3 prior approval requests, which were all denied. During that 90-day period, I acquired HIV. So today, I am a happy, healthy, thriving person living with HIV. Okay. But unfortunately, my story is not uncommon, and this has not necessarily been an easy journey for me. Before I had a confirmed diagnosis, I was extremely sick, and I honestly felt like I was going to die. So, I'm here to say that we must address the fractured PrEP system that makes our work to end the HIV epidemic in the United States much more difficult than it has to be. I'm also here to say that the current systems alone are not enough. So please, join our efforts to encourage President Biden and the White House to build a national PrEP program. Please scan the QR code on the table, sign the petition, and tweet President Biden, okay? And you can even tell him that Terrell sent you in the tweet. But please, make sure you tell him that we need a national PrEP program because ending the HIV epidemic in the United States depends on it. Thank you.
Mi nombre es Moisés Agosto y soy el director de tratamientos para EMMAC.
My name is Kenyon Farrow, and I'm with Prep for All.
Este es el momento de un programa nacional del PrEP en los Estados Unidos. PrEP for All, ENMAC, AVAC, the AIDS Institute, the National Coalition of STD Directors, NASDAQ, and AIDS United, les estamos pidiendo ayuda a ustedes.
Now is the time for a national PrEP program in the United States. And Prep for All, AVAC, MMAC, the AIDS Institute, the National Coalition of STD Directors, NASDAQ, and AIDS United are asking for your help.
Solicitamos un programa que cubra directamente medicamentos, laboratorios, servicios directos para personas sin seguro médico o con seguro insuficiente. Expandir una red de proveedores que incluya lugares de servicios no clínicos y teleprep y crear demanda a través de campañas nacionales y locales.
We are calling for a program that will directly cover medications, labs, and direct services for uninsured and underinsured individuals, expand a provider network including non-clinical sites and teleprep, and create demand through both national and local campaigns.
En la pantalla verán un código QR y un enlace a una carta que insta a nuestros líderes electos en el Congreso a hacer todo lo posible para financiar un programa nacional de PrEP. Les pedimos que apoyen este esfuerzo sacando sus teléfonos y háganlo ahora durante la plenaria, por favor. esfuerzos sacando sus teléfonos, escaneando el código y respondiendo a unas preguntas breves. Estamos solicitando firmas de individuos tanto como de organizaciones. También podrá encontrar la carta a través de la aplicación de la conferencia.
On the screen, you'll see a QR code and a link to a sign-on letter urging that our elected officials in Congress do everything they can to fund a national PrEP program now. Please take out your phones, scan the code, and answer a few quick questions to show your support. We are asking for both individual and organizational signatures. A link to the letter is also available on your USCHA conference app.
Si todos en USCHA nos apoyan, si todos ustedes nos apoyan y le preguntan a sus amigos para que nos apoyen y a los amigos de los amigos, podríamos llevar miles de firmas a estos políticos y enviarles un mensaje claro de que no podemos esperar más. PrEP es seguro, efectivo y necesitamos acceso ya.
If everyone at USCHA signs on, we can take thousands of signatures to these politicians and deliver the message that we can't wait any longer. PrEP is safe, it is effective, and we need PrEP access now.
Yes. Casi 400,000 nuevas transmisiones de VIH han ocurrido en los Estados Unidos desde que PrEP fue aprobada por primera vez hace 10 años, innecesariamente. Desde entonces, las comunidades negras, latinx y queer han seguido lidiando con el peor parte de esta devastadora epidemia.
Nearly 400,000 new HIV transmissions have occurred in the United States since PrEP was first approved 10 years ago. Since then, Black, Latinx, and queer communities have continued to bear the brunt of this devastating epidemic.
Sin embargo, no son las comunidades de color quienes reciben PrEP. De los 1.2 millones de personas estimadas por el CDC que más necesitan PrEP, solo el 9% de las personas negras y el 16% de las personas latinas han accedido a ella para el 2020, en comparación con el 66% de las personas blancas, además de solo 10.4% de las mujeres. Necesitamos lograr que estas comunidades reciban PrEP.
But communities of color are not the ones getting PrEP. Of the 1.2 million individuals estimated by the CDC to be in most need of PrEP, only 9% of Black individuals and 16% of Latinx people had accessed it by 2020, compared to 66% of white individuals. And only 10.4% of women in need of PrEP are getting it.
Esto es inaceptable.
This is unacceptable.
Una vez más les pedimos que por favor firmen esta carta como personas que viven, que son vulnerables y que están afectadas por el VIH para instar una acción inmediata.
Again, we ask you to please sign this letter as people living with, vulnerable to, and impacted by HIV to urge immediate action.
Una década es demasiado tiempo. Necesitamos un programa nacional de PrEP ahora.
A decade has been too long to wait. We need a national PrEP program now. Just want to send a special thanks to Rachel Klein of the AIDS Institute and Joe Huang Racalto of NMAC for fighting to make sure that this letter happened and that we could speak about this at the conference. Thank you.
Un saludo, mi nombre es Damián Cabrera y soy gerente de programas para la división de tratamiento en NMAC.
And I'm Rachel Deitch, she, her pronouns, with the National Coalition of STD Directors.
En los últimos 5 meses, casi 30,000 personas han contraído la viruela símica en los Estados Unidos y Puerto Rico. Ese número representa más de 1/3 del total de casos en todo el mundo y esto es indignante.
In the last 5 months, nearly 30,000 people have contracted monkeypox in the United States and Puerto Rico. That number makes up more than a third of the total number of cases around the world, and that is outrageous.
A medida que esta emergencia de salud pública se ha extendido, los hombres gays, bisexuales y otros hombres que tienen sexo con otros hombres, particularmente negros y latinos, han sido los más afectados. Y el 60% de los que adquirieron la viruela símica viven con VIH o arrojaron positivo en una prueba de infección de transmisión sexual en el último año. Esta enfermedad es dolorosa, costosa y estigmatizada, pero en gran medida es también prevenible y tratable.
As this public health emergency has spread, Black and Latino, gay, bisexual, and other men who have sex with men have borne the brunt of the outbreak. And 60% of those who've gotten monkeypox are either living with HIV or have had another sexually transmitted infection in the last year. This disease is painful, expensive, and stigmatized, yet largely preventable and treatable.
Necesitamos fondos ahora para pruebas, tratamientos, clínicas de salud sexual y proveedores en primera línea, alcance comunitario, vivienda y apoyo financiero para investigación y para quienes necesitan estar en aislamiento luego de contraerlo.
We need funding now for testing, treatment, sexual health clinics and providers on the front lines, community outreach, housing and financial support for those isolating, and research.
La Casa Blanca le ha dicho al Congreso cuánto dinero necesitan para montar una respuesta integral para poner fin a la viruela, y el Congreso no ha tomado acción. Lamentablemente, su silencio dice mucho sobre de quiénes le importa el dolor y de quiénes no.
The White House has told Congress how much money they need to mount this comprehensive response to end the outbreak, and Congress has done nothing. Their silence speaks volumes about whose pain matters and whose doesn't.
Les exhortamos a que por favor tomen unos 45 segundos en este momento, si es posible, para escanear el código QR y firmar la carta exigiendo que el Congreso haga su trabajo y financie la respuesta a la viruela símica. El código QR les llevará el formulario y a la carta tanto en español como en inglés, y se espera que tanto organizaciones como individuos son bienvenidos a firmar. También pueden encontrar un enlace a la carta en la aplicación de USCHA.
Please take 45 seconds right now to scan the QR code on the screen and sign the letter demanding that Congress do its job and fund the monkeypox response. The QR code leads you to the sign-on form and the letter in Spanish and English. Organizations and individuals are welcome and encouraged to sign. A link to the letter and the sign-on form is also available on the USCHA app.
Les pedimos que por favor se unan a nosotros hoy para exigir que el Congreso finalmente tome medidas para apoyar a nuestra fuerza laboral de salud pública, que ya de por sí está sobrecargada, y a aquellos vulnerables a esta enfermedad. Gracias.
Please join us today in demanding that Congress finally take action to support our overburdened public health system and those vulnerable to the disease. Thank you.
Hi, my name is Lauren Miller, and welcome to Real Talk with Inbang.
Please welcome the National AIDS Memorial and Quilt.
Yeah. Give it up. My name is John Cunningham, and I'm the Chief Executive Officer of the National AIDS Memorial and the AIDS Memorial Quilt. Before I begin my remarks, I would like to read the names of these panels, and then I would like, after those names have been read by myself, I would invite all of you to speak aloud a name or names of someone you want remembered today. Dr. Mark A. Colomb, Roxanne Hernandez, Dennis DeLeon, Eric Black, Glenn Banks, Jerome Hughes, Thrive, Harry Rentas. Please remember where we've been, where we have to go, and now I invite you to honor a loved one you've lost by speaking aloud names. Tony Lebec, Guy Kukan. And for all those names not spoken but held in our hearts, may we remember all those we've lost over the over 4 decades that we've been fighting against this virus. The National AIDS Memorial is honored to be here. It was an honor for us to spend time with all of you, and I want to thank anybody that put a stitch in these panels. These panels represent the best in humanity. For the work that goes into these panels when you sit around a table with others in your community that you may know or may not know, it is about healing, it is about storytelling, and it is about never forgetting. I don't need to tell anyone in this room that communities of color have been adversely impacted by this virus from the very beginning. At the same time, they did not receive the necessary funding, attention, and focus. The AIDS Memorial Quilt is no different. It is underrepresented from Black, brown, and other communities. We are committed to ensuring that the quilt will remember all those lost. We have launched an initiative, thanks to the generosity of Gilead Sciences, and with our partner, the Southern AIDS Coalition, called Change the Pattern. 2 weeks ago, I was in Jackson, Mississippi. Let's hear it for Jackson. Where for 7 days, we had the quilt in over 20 locations, out to the Delta, in Jackson, at the Mississippi Civil Rights Museum. We conducted programming where we brought different groups together and providers. We created bridges, but most importantly within the community, we spotlighted the need for increased access. Yes, it's about changing the pattern and reducing HIV rates in Southern communities and communities of color. But we know that in order to change the pattern, we've got to change the underlying symptoms of racism, stigma, homophobia, marginalization, and otherism. If we're going to get to zero, we're going to get to zero starting in the South. We continue to make panels. We will be in Montgomery, Alabama, planning a march over the Edmund Pettus Bridge, a march to zero. We invite you to be with us. Go to changethepattern.org, for together we can bring an end to this. We have it within our grasp. It is you in this room that can do it, and we welcome the opportunity to partner. Thank you all for all you do.
Ladies and gentlemen, please give a USCHA welcome to our host, Daniel Driffin.
Good morning, USCHA. Let's do it again. Good morning, USCHA. All right, so y'all know I'm from Atlanta, number one, and you know I'm a little churchy too. So look to your neighbor, okay, and say, neighbor, we made it. You can say it again for me. Look to your other neighbor and say, neighbor, we made it. Give yourself a round of applause. So I am Daniel Driffin, and I have the pleasure of serving as NMAC's Monkeypox Coordinator. Outside of my responsibilities serving in the Monkeypox Coordinator, I also serve as a project manager with the HIV Vaccine Trial Network. To have those beautiful panels in front of us just moments ago, and seeing members like Glenn Banks, Jerome Hughes, and Eric Black, who specifically were some of the earliest supporters of Thrive Support Services, it warms my heart today. Yesterday was Indigenous Peoples Day, and today we have the opportunity to celebrate specifically National Coming Out Day. National Coming Out Day specifically supports individuals who are lesbians, gay, bisexual, folks with trans experience. But oftentimes, those people, especially if they're black and brown, they have to come out many, many times. So as we think about providing additional empowerment and support to those along our communities, provide love, provide feedback, and support like never before. So we have our federal, we have state, and we have local partners who will join me on the stage, specifically to address our federal response to the emergence of monkeypox. Our first speaker is Dr. Tamer Khan. Dr. Khan is the Associate Medical Research Director, Infectious Disease and Primary Care Provider with Fenway Health. He will specifically bring some frontline perspectives of the current outbreak. Let's welcome Dr. Khan.
We're good? There we go. Hi, my name is Tamer Khan. I am grateful to be here. I want to thank the organizers and the city of San Juan for organizing this conference. As stated, I am the Clinical Research Coordinator as well as the Associate Medical Research Director of the Fenway Institute. I'm also an ID specialist and a primary care provider at Fenway Health. And I've been asked to speak about the frontline experience for some of us that have had to deal with monkeypox on a local level. I use he, series pronouns. So a little bit about where I am. I'm in Boston, Massachusetts. I work at a federally qualified healthcare center. We serve about 35,000 patients. 2,200 of those patients are living with HIV. About 5,000 patients have been prescribed PrEP in the last year. And we center, our focus is on the well-being of the LGBTQI+ community. And within the organization, we've got the Fenway Institute, which does a lot of research, advocacy, and policy work. We even are part of the HPTN and HVTN networks that look at HIV prevention and treatment. So monkeypox, just to get everyone on the same playing field, as we've heard through the headlines and the previous speakers, is a DNA virus. It is closely related to smallpox. And even though it's called monkeypox, we know that it likely started or has a reservoir within a rodent species in Western Africa. But the data is still needed on whether or not how accurate that information is. When looking at transmission of monkeypox, what we do know is that it comes from close contact. And it has started to act a little differently. Previously, though, the first case of monkeypox occurred in 1970 in Western Africa, in the Congo Basin. And then we did have sporadic cases and outbreaks in that region. The first notable case in the United States occurred in 2003 when imported livestock caused a slight outbreak in the Midwest. And we believe that prairie dogs were kind of part of that equation. Now, the most recent headlines we've been seeing have been coming from Europe early on in May, with our first case happening in the United States in Boston on May 18th of 2022. Early studies looking at the first 500 cases of monkeypox patients across 16 countries noted that about 98% of these patients were gay or bisexual men who have sex with men. And about 40% were people that were living with HIV or were on PrEP. A majority were on PrEP, rather. Of the early cases, these are the cutaneous symptoms that we saw. We saw penile lesions, we saw oral lesions, we saw perianal lesions. And this doesn't even include the morbidity of pain, stigma, fear, anxiety, etc. As I've mentioned, in addition to the rash, we also have cases that had fever, headache, lymph nodes that were swollen, and some severe cases of proctitis where people are having inflammation, bleeding, and pain in the rectum. We had one case at Fenway that had eye involvement that had to be sent to the hospital to get IV antivirals. Here's a graph that looks at the cases in Massachusetts only, so this does not account for the rest of the United States. As mentioned, we were the first case in Boston at MGH to have a diagnosis on May 18th, whose symptoms started on the 4th. And as you can see, there's an uptrend that occurs, and I want to be careful not to imply any causation, meaning one thing caused another or affected another directly, but there is association where these things did happen together. So once cases started to become prevalent, we had a lot of anxiety in the community. We had a lot of providers that were anxious. We had patients that were anxious. And we saw an uptick once we got more testing available, which was hard to do given the fact that a lot of it was done at the state level. As mentioned, there's some management things that occurred at this point. We had a vaccine that came out, that became available, the Jynneos vaccine. And I put two arrows there because the first arrow showed the restricted use of this vaccine. This was only as PEP, post-exposure prophylaxis. So someone who was diagnosed was able to give this to someone that was close to them, either a sexual partner or intimate partner. The second arrow shows we were able to give it to more people. However, I wanted there to be a caveat. We had limited supply at this point. So it was not widely available, and we were having them, people were signing up within minutes before we could get additional supply in. On the first week of August, August 4th, Biden declared a federal emergency with monkeypox. On August 5th, we started providing TPOXX, or tecovirimat, for our patients who had pretty moderate to severe disease. And this was after, thankfully, we received some federal guidance to decrease the amount of paperwork that was involved in getting this drug. But still, there was an outcry from our patient population that they didn't get this drug soon enough. However, it has been available to about half the patients that were diagnosed with monkeypox at our facility. I want to be clear, yes, numbers in Massachusetts have gone down, but what we are seeing is that the proportion of cases that are mild has gone up in people that have been partially or fully vaccinated. And what we aren't capturing is the cases of people that aren't getting tested or treatment. There's still stigma out there. There's still people that are fearful of being seen with this and seeing providers. There are PCPs who may not be well versed in this language. And so I want to name that before I start showing any kind of numbers or anyone else does. I also want to name that there's a relationship between HIV and monkeypox. In the United States, about 23% of men who have sex with men are estimated to be living with HIV. Among the 2,000 monkeypox patients whose US data was collected by the CDC, 38% had HIV, which means this population is disproportionately affected. My colleague Naseema Shafi at Whitman Walker also stated that they saw severe cases of monkeypox in patients with HIV with low CD4 counts, with very severe disease, not responsive to antivirals. And this is my last slide, and this is all I want to leave you with, is that this does not happen in a vacuum. The response is multifaceted, and it includes at the top healthcare providers, pharmacists, behavioral health specialists, patient advocacy groups. It involves human beings with their own stresses, bandwidth, and emotional toll, just coming out of a pandemic and still in one, actually. Clockwise, data, research has been limited. We are using old data that is limited to smallpox and/or animal studies. So we need more information, and that requires more funding and more staffing. Next, stigma, isolation. This still is affecting a population that is marginalized. Next up, money and funding, to which I'm sure we're going to hear more about from the federal colleagues of mine. And then lastly, equity. We are seeing that a lot of the people in our area in Massachusetts that were able to obtain either treatment, vaccine, or any kind of advice were predominantly white cis men. And we know now that the numbers for monkeypox are actually affecting those that are BIPOC. So with that, I will turn it over to Daniel and allow our federal colleagues to take over. Thank you.
Thank you, Dr. Khan. Let's give him another round of applause. So next up, we have Dr. Jonathan Merman, who is the incident manager at the Centers for Disease Control and Prevention, specifically on the monkeypox response. He's usually the director of the National Center for HIV, Viral Hepatitis, STD, and Tuberculosis Prevention. Dr. Merman, come on up.
Thank you, Daniel, and buenos dias. I really appreciated the great talk from Dr. Khan, and for all of you who stayed to the last session in the last day of this conference, you really care. I also wanted to appreciate that the organizers brought the quilt. It always, opens holes in my heart and reminds me that that it's doing that for others too, and energizes me to do more in my day-to-day work. Last year, COVID hit us really hard, and just as it was getting better, monkeypox showed up, and I think that brought a lot of challenges with it. But COVID left us wiser and more weathered, perhaps like tough, grizzled old people, and I think it also left us with some new scientific innovations and some experiences that could be applied to a new outbreak of monkeypox that showed up unexpectedly. Reflecting on the past, I think that we have done better with monkeypox than we did in the beginning of HIV, though we've also had some challenges. Communities did come together. 38% of people who have had monkeypox in this country have HIV, and the vast majority have been gay, bisexual, and other men who have sex with men, transgender men and women, and other non-binary persons. So naturally, the HIV community, the people who came to this conference, were the first to act, and those that had the experience and motivation to do the most. And we have turned the corner, although we are not yet done. And I'm grateful today to be at this podium with a different virus and some different tools, but with colleagues and friends out here in the audience and behind this hidden screen who are all working together to really end this outbreak. So any discussion about monkeypox starts with the recognition that the situation that led to this global epidemic began years ago. Epidemics occur within social, political, and community environments, and its rapid and massive spread throughout the world is because of this, not in spite of it. So what was the state of our syndemics when monkeypox hit? Well, first, we have a struggling, inadequate infrastructure for sexually transmitted infections. In real monetary value, federal and state support has plummeted. There are fewer STI clinics, fewer staff, and few new tests or treatments for sexually transmitted infections. Antimicrobial resistant gonorrhea and syphilis are increasing, and in the midst of this, the US and many other countries suffer from systemic homophobia, racism, and economic policies that are associated with increasing STIs and their persistent racial and ethnic disparities. MSM and transgender persons bear the largest brunt of HIV, syphilis, and gonorrhea, and new discoveries such as the fact that having an undetectable viral load prevents HIV transmission and pre-exposure prophylaxis prevents HIV acquisition have led to reductions in HIV incidence and changed the prevention landscape, making it easier to avoid HIV, but not necessarily STIs. We've been facing an increasing incidence of STIs for the past 7 years, to the point that COVID-19 aside, 80% of all cases of reportable disease in the US and territories were sexually transmitted infections. So this figure highlights the increasing incidence of gonorrhea over the past decade, concomitant with a vastly disproportionate rate of infections among MSM. So over 40 times that of women and men who have sex with women. Similarly, half of all primary and secondary syphilis, the stages of disease that reflect recent infection, occur among MSM. And for syphilis, about 40% of cases occur among people with HIV. So when monkeypox arrived, it did so in a struggling public health and social system rife with health inequity. Previously, as Dr. Khan had highlighted, monkeypox virus had caused limited numbers of cases and small outbreaks in West and Central Africa. And there was a small outbreak in the US in 2003 associated with importation of animals. Monkeypox was not a cause of morbidity or mortality, at least in a major way, in the countries in which it was an endemic. Cases, however, were increasing in frequency, probably because fewer people had immunity from smallpox vaccination, which also reduces the chance of getting monkeypox. And industrialization and transportation put more people in contact with the potential animal host. There are several major clades of monkeypox virus. Clade 1 causes more severe disease than clade 2 or 2B. 2B is the clade that's causing the current multi-country outbreak. And historically, because of the potential for spread and severe disease, there's been concern for the use of monkeypox and smallpox as biological weapons. And vaccines had been a component of the US Strategic National Stockpile. However, the sudden spread of monkeypox this year was not expected, including the major route of sexual transmission. But as Dr. Daskalakis' colleagues and I wrote recently, all outbreaks begin somewhere. They enter social networks and spread based on characteristics of the pathogen, the host, and the way people in the initial affected network live, work, travel, and play. An analogy that began with economic theory is a black swan. A black swan is an unpredictable event that is beyond what is normally expected of a situation and has potentially severe consequences, and notably a widespread insistence that it was obvious in hindsight. Because there had already been some concern about monkeypox, I think this really is a gray swan, an event that is possible, known, potentially extremely significant, but considered not very likely to happen. But it did. And within a few months, cases surged in the US, but also reached a peak in the beginning of August, and have had a relatively consistent trend downward since then. However, over 26,000 people have had this painful infection, and although we are doing better, we're definitely not out of the woods. Including in Puerto Rico, which has not escaped monkeypox, with almost 200 confirmed cases, although like the continental US, there is a downward trajectory here. So just as we've seen with many other infections that are sexually transmitted, MSM and transgender persons are disproportionately affected by monkeypox. And this is dramatically so, with pink numbers also being seen in people aged 21 to 40, although cases have occurred among people of all ages. So those dark blue bars are men, and the others are really small proportions. And just as we learned from HIV, STIs, and COVID, in an unequal society, health disparities will naturally form unless concerted effort is to put into place and sustained. And even then, it is hard to achieve health equity. In this figure, we can see that even though monkeypox incidence has decreased for all races and ethnicities, over time, the proportion of cases among African Americans has grown, and reversing this trend is now a major effort. I believe the decrease in cases over the past few months reminds us that community response, public health action, and science matter. In this slide, you can see that in response to the monkeypox outbreak, gay, bisexual, and other MSM changed their behavior, with a 50% of respondents on a survey reporting a reduction in numbers of sexual partners, one-time sexual encounters, and sex with partners met on dating apps or at sex venues. In addition, relatively rapid acquisition and distribution of vaccine aided prevention. Over 800,000 vaccinations have occurred, and the figure on the left indicates the estimated incidence of monkeypox cases among vaccinated and unvaccinated persons beginning 14 days after the first dose of Jynneos vaccine. People who were not vaccinated had rates of monkeypox 14 times that of vaccinated persons. And these are preliminary data, and formal vaccine efficacy assessments are being conducted. However, because of the short time frame of follow-up following vaccination, the fact that most people had not yet received a second dose, and because some people would have received vaccine after exposure, it is possible the ultimate effectiveness of vaccination may be even better. In this slide, the dark bars show total first doses of vaccine administered, and the light blue line indicates second dose. As you can see, most people are returning for second doses. However, the total number of persons getting first doses has dramatically decreased. And we've had data that Latinos and African Americans are less likely to receive vaccination than others. This may be one reason that disparities have increased. In response, the White House and CDC and other partners have been working to expand use of vaccine. One method has been to recommend intradermal rather than subcutaneous placement, which needs only 1/5 the amount of vaccine, thus increasing supply. And the other is to provide flexible guidance as to the anatomical placement of the intradermal vaccination to decrease the chance for stigma. Another method is a vaccine equity initiative that brings vaccine to people who would benefit, primarily Latinos and African Americans, through event-based and venue-based programs. And there have now been several examples of considerable success providing vaccine to people where they are, at Southern Decadence or Gay Pride events. Actually, let me go back. So, monkeypox has taught us lessons and left us with some obligations. The first is to remind us that as societal concern decreases, public health needs often increase. Our careers are focused on the difficult task of caring for the people and issues that many others don't. To do that, we will need to focus on equity from the beginning and to learn how to do it well. We are obligated to bring services to people rather than asking them to come to us, and to set up the structures, policies, and interventions that make prevention easy. Communities matter. We wouldn't be here at USCHA if we did not recognize that. To gain and sustain community, trust takes time. Trust is a gift that has to be nurtured. Bayard Rustin said that the proof that one truly believes is in action. In HIV, we reduced incidence by over 75% since its peak in the mid-1980s, and we've seen some partial reductions in the most glaring disparities. But there is more to do. To end monkeypox and the HIV epidemics, and to do it soon, we need to do even better. I can speak for CDC and for my center staff and state unequivocally that we are committed to working alongside all of you to continue fighting until the end, knowing that it will not be easy. Thank you.
Thank you again. Community matters and equity matters. Really, really important. So next up, we have Dr. Susan Rabalato. Dr. Susan Rabalato is the director of the Division of State HIV/AIDS Programs at HRSA's HIV/AIDS Bureau. Currently, she is also the lead for HRSA's monkeypox response. Dr. Rabalato, thank you.
Perfectly together, and tell me, boy, no one let me sweet.
Thank you. Thank you for having me today. I'm sitting amongst distinguished colleagues, many familiar faces, and I'm really happy to be here to talk about the Health Resources and Services Administration, or HRSA, programs, particularly the HIV/AIDS Bureau's Ryan White program, and about the response to the monkeypox virus. So the Health Resources and Services Administration supports more than 90 programs that provide health care to people who are geographically isolated and economically and medically challenged. HRSA does this through grants and cooperative agreements to more than 3,000 awardees, including community and faith-based organizations, colleges and universities, hospitals, state, local, and tribal governments, and private entities. Every year, HRSA programs serve tens of millions of people, including people with HIV, pregnant women, mothers, and their families, and those otherwise unable to access quality health care. Part of the HRSA's HIV/AIDS Bureau administers the Ryan White HIV/AIDS program, the largest federal program focused specifically on HIV. The HIV/AIDS Bureau's focus is to ensure that all people with HIV in the United States have access to high-quality HIV care and treatment that is critical to ending the HIV epidemic in the United States. Through leadership and resources, HAB works to improve health outcomes and reduce health disparities. This graphic represents our priorities and organizational principles. It provides a visual framework for our work and shows how the organizing principles are the glue that hold this all together. The Ryan White program provides grants to establish and maintain a comprehensive system of care and treatment for low-income people with HIV. Through the Ryan White program, HAB funds grants to cities, states, counties, and local community-based organizations to provide a comprehensive system of HIV primary medical care, medications, and essential support services for low-income people with HIV. The program is divided into parts that provide flexibility that allows jurisdictions to enhance the system of HIV care and treatment that meets the needs of the community. Ryan White recipients determine service delivery and funding priorities based on local needs and planning processes. The Part A grants fund core medical and support services to metropolitan areas most severely affected by HIV. The Part B grants fund states and territories to improve the quality of and access to HIV healthcare and support in the United States. This includes medication access through the AIDS Drug Assistance Program. The Part C grants fund outpatient ambulatory health services and support for people with HIV through community providers and help community-based groups strengthen their capacity to deliver high-quality HIV care. The Part D grants are for local community-based organizations to provide medical care for low-income women, infants, children, and youth, and to provide support services to people with HIV and their families. The Part F funds are for multiple programs that build capacity and include the dental program, the AIDS Education and Training Centers, or AETCs, the Special Projects of National Significance, the SPINS programs, and our Minority AIDS Initiative programs, which help recipients improve HIV care and health outcomes for minorities. In 2020, the Ryan White program provided services to nearly 562,000 people, more than half the people diagnosed with HIV in the United States. Of the Ryan White clients receiving medical care in 2020, 89.4% were virally suppressed, exceeding the national average of 64.6%. As just mentioned, the Ryan White client population accounts for more than half of all the people diagnosed with HIV in the United States, based on HIV surveillance data. You can see here some characteristics of the clients served in 2020. Nearly 3/4 of the Ryan White clients are from racial and ethnic minority populations, and approximately 61% are living at or below the 100% of the federal poverty level. In addition, 6.9% of clients had temporary housing and 4.8% had unstable housing. Almost 61% of the Ryan White clients receiving medical care, 89.4% were virally suppressed. In addition, the HIV medical care treatment and support, our Ryan White HIV AIDS program recipients are helping to combat the COVID-19 pandemic, and most recently, the monkeypox outbreak in the United States. Thank you for your comment. I will do that. Since the onset of monkeypox outbreak, HRSA has been working closely with the Department of Health and Human Services, including the Centers for Disease Control, to monitor the cases of monkeypox in the United States and provide resources to help healthcare providers who treat patients who have monkeypox or may be at risk for monkeypox. Recognizing that the Ryan White recipients are trusted providers in the community most affected by monkeypox, HRSA's efforts have focused on providing up-to-date information and resources to help the Ryan White providers address monkeypox in their communities. The HIV/AIDS Bureau included monkeypox updates from the CDC in our June, August, and September Have You Heard webinars, which are our monthly webinars for our Ryan White recipients and partners. We also have a monkeypox information webpage at our website, ryanwhite.hrsa.gov, which houses resources and guidance for Ryan White recipients, subrecipients, and stakeholders. This webpage includes links to the Have You Heard webinar recordings, clinical updates and guidance, and other resources to help Ryan White recipients navigate the monkeypox outbreak. HRSA has also been working with Ryan White recipients to leverage resources to respond to the outbreak. This letter to recipients, HRSA outlined the allowability of Ryan White funds to provide the diagnosis, treatment, and vaccination of monkeypox. HAB continues to work to assist recipients in addressing this outbreak. In August, HRSA received an allotment of the Jenios vaccine for MPX for rapid distribution to Ryan White recipients to help reduce the outbreak among those most affected. HRSA was identified as a distribution point due to the healthcare services we support for individuals with HIV and the large number of uninsured and underinsured patients seen at our duly funded Ryan White and Health Center programs. To expedite dispensing the Jenios vaccine, HRSA provided the vaccine to 50 Ryan White Part C duly funded health center programs that care for a significant number of men who have sex with men and transgender persons. The identified providers already had access to the necessary health partner ordering portal, which aided in quickly getting the vaccine to clients. The entire allotment of Jenios was quickly distributed to identified providers who requested vaccine. With the updated guidance from CDC that pre-exposure prophylaxis with Jenios vaccine should be offered to people who may have been exposed to monkeypox, HRSA notified the providers who received vaccine with the new guidance so that they can expand vaccination to include PrEP. In order to prepare an event that HRSA receives more Jenios for distribution, HRSA is working to enroll duly funded Ryan White Part C and Community Health Center program recipients with significant numbers of MSM and transgender clients into that health partner ordering portal. This will allow for rapid distribution of vaccine if it becomes available. With the updated guidance from CDC, we're working with our recipients to make sure that as many people who need vaccine are able to get vaccine. For additional information about this initiative and to view the list of providers who received vaccine to date, please visit the website at hrsa.gov/monkeypox. HRSA also has additional resources that may be helpful to Ryan White recipients and their partners on the web pages and links listed here. As the monkeypox outbreak evolves, the new information becomes available. These resources are being updated. If you have any follow-up questions regarding monkeypox, the Ryan White program, or HRSA, you can reach out to me. My contact information is here. You can also find out more about the HRSA programs at the HRSA website. Again, thank you for allowing me to participate today, and we're looking forward to working with you continually to address the monkeypox outbreak as well as end the HIV epidemic.
Thank you so very much, Dr. Susan Rapalato. Next up, we have Dr. Dimitri Daskalakis. Have you guys heard of him? Okay, all right. Dr. Daskalakis is the Deputy Coordinator on the National Monkeypox Response at the White House. He's deployed from CDC currently, where he serves as the Division of HIV Prevention Director. Dr. D, come on up.
So first, hello family, how are you? So good to see you. Thank you for sticking out until the end. So I'm gonna do a little bit of something different because you've heard from very important principal agencies, CDC and HRSA, what they're doing. I'm just gonna put it all together in a different way because of what my role is at the White House. And so I'll say first, greetings from Bob Fenton, who's the coordinator at the White House. He's from FEMA, and I'll tell you, he has been an amazing person that has worked so hard to move forward the monkeypox response. And I'll just tell you, that's really what the role has been at the White House. It's been to take the work that's happening at the agencies, to listen to the community, and really to accelerate the work that's being done to get closer to control control and containment of the outbreak. And so I want to just give a quick moment to think about what the strategy is to address monkeypox. We start at the base with a syndemic approach, build on community engagement, and equity really at the core of what we do. From that, we move on to pillars. There's messaging, there's testing, there's prevention, and there's treatment, with the goal of controlling and containing monkeypox, and then the aspirational goal of eliminating monkeypox domestically. When looking at this, it is illuminated by a plan for a global response as well as research, since it's so critical to move the science forward to address the monkeypox outbreak. So let's first talk about the syndemic approach. You heard it in motion with the two previous presenters. Dr. Merman talked about the CDC work. Dr. Robolato talked about the work at HRSA. Monkeypox, as you've heard over and over again, is not a disease that lives in isolation. It is, in fact, one of the strongest case studies we've had in recent history for why a syndemic approach is so critical to addressing not only this outbreak, but potentially other outbreaks in the future. Flexibility from HRSA, flexibility from CDC and funding, flexibility from SAMHSA and funding, and more organizations coming on board soon really addresses and highlights the importance of that syndemic strategy that is the ground on which we build this response. Now, the next level, equity. So there's so much that has happened in the equity space. And as you've heard, we really start in a place where equity and disequity is actually expected as what happens in this environment. So it is not surprising that we have inequitable distribution of vaccine, that we have inequitable distribution of cases. But what's critical is that engagement and that connection to the community really helps us move things forward in a way to address the stigma as well as the systems that block us from being able to achieve not only an end of an outbreak, but an outbreak that ends equitably across populations. So a couple of examples on this slide. Listening to the community with the intradermal vaccine, we heard loud and clear that it shouldn't just be on the forearm. That's stigmatizing. Some people don't want it there. So adding the back and adding the deltoid, really important. Transparency of data, actually showing people what we know and what we don't know through really good risk communication. That builds confidence, and that builds confidence in vaccine. It builds confidence in the system and the providers of that vaccine. So even though we don't have perfect data, the example being the vaccine performance that's been released by CDC, opening that door and showing what we have at the beginning helps us build. And then there are programs that really address equity on the ground. And I'm really excited to say that USCHA, the Ministry of Health of Puerto Rico, CDC collaborated together to bring vaccine here around this conference. So amazing, but there have been several other events throughout the country that demonstrate it is not about build it and they come. It is about bring the vaccine to the people, bring the messaging to the people, bring it closer to where people are. Whether it's at a sex club or Black Pride in Atlanta, what we've seen is that people take you up on the offer when it's given to them in a context that they understand. And that is a core tenet of equity, but also a core tenet of messaging. So I always tell this story about the monkeypox safer sex guidance. It is directly referencing something from the HIV epidemic. In the early 80s, a group of community advocates came together and wrote a document that said how to have sex in an epidemic, one approach. Was their data perfect? No. Did they know everything about HIV at that time? No. So it's important that governmental public health steps up and says, we learned this lesson from 41 years ago. And so CDC released guidance on safer sex before we knew everything about monkeypox that we know. This is an unprecedented outbreak. As you've heard from all the previous speakers, it's not moving the way normal monkeypox moves. It's doing something different. So putting it out there, good risk communication that says, I'm telling you what's the right thing to do today, but the science is going to tell us if that changes. So expect a change. Not only is a lesson for monkeypox, it's a lesson for all outbreaks and frankly, all of public health. Messaging in a way that people understand, using trusted messengers, increasing transparency. Up there I put this letter from the FDA that when the intradermal vaccine began, they generated a one-pager that just said, this is what we know, this is what we don't know, and this is what we have to learn. The hubris of saying we know everything from day one is a mistake. And so really, the pattern that you're seeing in monkeypox, though we can do better and have so much more to do with messaging to make sure we reach the communities overrepresented in the outbreak and underrepresented in vaccine, we have gotten closer to the light. And that's because it's on the back of a syndemic. It's on the back of HIV, it's on the back of STD, it's on the back of viral hepatitis. Testing. So we've seen some really significant improvements in testing. We've gone from 6,000 tests per week available to 80,000 tests per week available, but it's not enough. What we need is different kinds of tests. We need to have multiplex testing. We need to be able to see someone who has a lesion, swab it, and say, is it HSV? Is it herpes? Is it syphilis? Is it monkeypox? That's what we need. We need home testing. We need the ability to do a point-of-care test where you walk into the clinic and you say, I have a lesion. They swab the lesion and they tell you, yes, monkeypox, no monkeypox. So though the infrastructure is there, it needs to be built out. And that infrastructure, there's a theme here, is built on the back of HIV, STD, and viral hepatitis, because monkeypox does not live in isolation. It doesn't live in isolation for testing. It doesn't live in isolation for prevention. And it's critical to remember that syndemic approaches not only address monkeypox, but address the other pieces. Someone who's getting tested for monkeypox should be tested for HIV. Someone who's tested for monkeypox should be tested for STIs. Someone who tests positive for monkeypox or negative should be offered PrEP. If they happen to get tested for HIV, which they should, and they test positive, what a great opportunity to link them to care and services. And now moving on to prevention, and this is the love song to the family, which is that a lot of work happened to help people prevent monkeypox, but the main work that happened because of you, because of the community that listened and heard the messaging, and not only heard the messaging, but took it upon themselves to adapt it and amplify it to people. And the effect is that we saw, as Dr. Merman said, people change their behavior. We know that can't last forever. And that's why it's so critical that we work diligently to move vaccine into people's arms and the people's arms who are overrepresented in the outbreak. This outbreak moved differently than expected. We started with a plan to do PEP. That didn't work out. We didn't know everyone's contacts. We moved to PEP++. And then, because of diligent effort to increase vaccine supply, we're able to move to a PrEP and PEP stance where more people are able to access vaccine. The problem is, the easy part is over. You saw the slide with the hump. We've seen the early adopters. They've gotten vaccine. Now we have the hard work to do. Vaccine supply is great. I actually put up there, the community asked us to be transparent about vaccine supply, and every week we put a posting up on the ASPR website that actually tells you what vaccine we have, what vaccine we expect, and what vaccine is going to look like in a few months. So really important, again, engaging and listening. And another really important piece is leveraging what we know in HIV. And so one of the things that we learned in COVID is that pharmacies are really good places to do vaccine. In fact, during some parts of the COVID vaccine effort, 70% of the individuals who were being vaccinated at pharmacies were Black and Latino. And so the PrEP Act was just amended last week that allows pharmacists to give vaccine. We're going to be working with Ready, Set, PrEP through HHS to actually get vaccine to those pharmacies so that we can get vaccine into people's arms in a way that is potentially less stigmatizing. Pharmacies are a little bit less threatening than vaccine sites that say you have to be a gay man who has a lot of sex. So I think pharmacies are a bit more straightforward. So as we get more vaccine into pharmacies as well as to providers, this is all in the effort to really address that final mile, which is to get vaccine to people who were not the early adopters. And then there's treatment. TPOXX, tecovirimat, is an investigational drug. As you've heard, a lot of work has happened to make sure that access is easier with reduced paperwork with the EIND. Additionally, the community asked, please put up the demographics of the people getting TPOXX. And every week, CDC updates the demographics and it's available for you to see. And the good news is that the disparities in treatment are not as stark as the disparities that we see in vaccine and in cases. We're not done yet because research illuminates our work. We know that this drug is safe. We don't know if it's effective. We've heard a lot of anecdote. And right now, the NIH is recruiting the STOMP trial, which is a really important study that will give us the data that we need, not just for this outbreak, but for future challenges of monkeypox down the road. And then, illuminating this temple is a global strategy as well as research. So I'm showing the photos of Jeremy and Hank, who are the international team, the global team at the White House working on international plans. If we do not control monkeypox internationally, we will not be able to control it domestically. So the work is really important and we're in lockstep. But I also want to talk about research and how important that is. We need new tests, multiplex tests. We need to understand vaccine and immunocompromised individuals. We need to make sure that people are able to see data and new information about monkeypox. And we've made a stride in that direction with data that's released on PubMed through articles not requiring a paywall anymore. We've set research priorities for monkeypox, and based on community request, we have created a website where you can go on the HHS splash page for monkeypox, and you can actually see all the studies that are being supported by the US government and what their status is across the entire monkeypox portfolio. So really important. So I want to end and ask you a question. Are there lots of temples, or is there one temple? I want to tell you that the syndemic strategy tells us that there should be one temple. When you're looking at this picture of our strategy at the White House for how to end the outbreak, I'm going to remind you that just last week, another important strategy was released, which was the strategy of the Division of HIV Prevention at CDC. And it's interesting how it's identical, because the syndemic strategy is the way to control outbreaks, a national PrEP program, a fully realized ending the HIV epidemic, and adequate funding for STD clinics is the way to keep our system warm. So when it has to heat up, we can flip the levers faster. We can work and have the individuals, the people, the resources that know how to interact with the community and execute and implement infectious disease responses, do it. Supporting HIV, supporting STD, supporting viral hepatitis, and yes, supporting mental health, all come together to remind us monkeypox is the case study we cannot forget. We need support in those areas so that the next outbreak, which is inevitable, will land in a temple ready to address the challenge. Thank you.
Thank you, thank you, thank you. Remembering there's one temple, using HIV to keep the flame hot to answer other outbreaks, as we shall see. Thank you, Dr. D. Next up, we're going to shift over towards a more regional and local approach, and we invite Joanne Moore, the Deputy Commissioner of Health Equity and Human Rights from the New York State Department of Health. Joanne, come on up for me. Thank you, Fred. Thank you.
Woo! Absolutely. Woo! All right, good afternoon, all my friends and all my colleagues. It is an honor to join everyone here on this stage, and it is an honor to stand before you to get the opportunity to talk about one of my favorite places, New York State. Excellent. New York is in the house. So, after sharing the last 4 days with so many of you and having the opportunity to listen to the storytellers and listen to the teachers, what it reminds me is that the experience that I want to share with you about what's happening in New York isn't so unique, in that there are so many collective themes that we share as we try to do this work together to serve others. Like many of your jurisdictions, New York faces challenges. Stigma. Can you imagine if compassion was able to move as quickly and as deeply as stigma, what this world would look like? Our own fear of creating stigma, the fear of weaponization of this outbreak against the LGBTQ community, the LGBTQ New Yorkers, who have faced longstanding discrimination simply for who individuals are and who individuals love. Stigma has been a historic and persistent challenge. Disparities. The persistent and chronic disparities that always disproportionately impact Black and brown New Yorkers and communities across this nation, furthered by racism, homophobia, and the barriers to accessing basic determinants of health. And then, of course, the limited resources. The challenge that comes in multiple forms, human resources, because people are tired. Funding that isn't already allocated and supporting other essential services. And then at times, the tools, vaccination access. Like you, like your jurisdictions in New York State, we also have many competing priorities. Multiple immediate public health responses, in addition to historic public health priorities that are exasperated by the newer immediate threats. However, also like all of you, those of us in New York, in spite of those challenges, get up every single day and respond. We take action. Our response as it relates to monkeypox has been multifaceted. Scaling up testing efforts by continuing to add the number of laboratories and spaces in which people can access testing. Public messaging that doesn't stigmatize and blame, yet prioritizes the most at risk of communities while reinforcing that everyone is at risk for transmission. Clinical guidance, data collection, and data analysis that's used to determine allocation and distribution of funding and services, such as vaccination. All based on the input of community, of individuals with lived experience, and with our partners across the state. So if you listen to what I just described, what you're saying to yourself is, but that's not new. Is it innovative? What it is exactly what we've been doing for decades upon decades, because in reality, we know that if we persist in the steps that I just mentioned, if we create the frameworks that are based on the history of evidence, we can succeed. It takes time, though, and for many of us, we become impatient. But what we cannot do is cease to respond. Communication and planning with community stakeholders to inform messaging. Partnering in New York State is an example with our local health departments, community-based organizations that have always been the root and the first face of our communities, all to leverage expertise, experience, lived experience, and trust, the foundation of how we engage with others. When we respond to monkeypox and other public health threats, we are responsible in following the science and empowering those at greatest risk and determining the best paths to ensure the most people are reached in the most possible of ways. A meaningful, intentional way to do this is policy change. So for example, in New York State, we quickly recognized that individuals under the age of 18, outside of having parental or guardian consent, were not able to access the prevention services that we had available. And in fact, individuals under 18 who otherwise would have been eligible to receive support were being turned away. So in the effort to empower those also recognized as being at risk, we had to take serious intentional steps to change policy. And as a result, we ended up putting together an emergency regulation that in New York State will allow for individuals under the age of 18 to be able to consent for access to prevention, as well as other other components, such as vaccination in New York State. The emergency reg that we offered is a 90-day regulation that will give us the time to continue to do our assessment and analysis to determine what is best for individuals. And what the regulation does is it adds monkeypox as an STI, a sexually transmitted infection. Because in New York State, that is the only way in which we are able to allow for minors to consent to STI prevention and treatment. So it takes at times, we know we need to be innovative, and we also have to take risks. It takes coming to the tables and creating the spaces so that those in the community who are most impacted by the decisions that governments make have input and have the ability to share their experience and understanding. And those are all of the things that we did to make a decision that we know has a broad impact. So at the end of the day, I think we all share the same goal. And for me and for my colleagues, our goal is to achieve sustainable change. We must find our ways past intermittent periods of success and marginal change in public health outcomes. We need a long-term impact as it relates to our response to monkeypox and every other public health crisis that our communities, our friends, and our loved ones face. I often hear progress over perfection. Here is my challenge to all of us. Let us strive for progress to achieve perfection, however perfection may be defined. Thank you.
All policy is local. The impact is real, and reducing stigma and discrimination is possible, especially when using frameworks of health equity. Thank you, Joanne. Finally, we have Julio Frosto from Bienestar, a community-based organization located in Los Angeles, California. Julio will shed some light on a community response. Julio, come on up for me.
Buenos días a todos. My name is Julio Frausto, and I am here representing the amazing, hardworking community of Southern California. I'm going to share briefly how we experienced the initial response and the initial offset of the monkeypox virus outbreak. I am a clinical case manager for Bienestar Human Services in Los Angeles, California. Bienestar is a nonprofit organization committed to improve the health and well-being of unrepresented communities of color in the greater Los Angeles area. We aim to achieve this through education, prevention, mobilization, advocacy, activism, and direct support. However, this vision was put to the test during the early stages of the outbreak of the monkeypox virus. Because a large segment of our work is serving people living with HIV, some of our HIV-positive clients reached out to us to confirm or deny the information they were receiving or that they were getting through the social media. As we all here know it, misinformation is sadly more prevalent in social media platforms than we wish it would be. In the beginning, even our local health department did not have answers to some of these questions. We were just perplexed. The only thing that remained constant, though, was this phrase: infections are mostly affecting gay men. As the vaccination process was announced and rolled out, the information was decreasing even more so. For some unknown reason, our local news media did not think it was important to spend more airtime informing the affecting communities. There was even a more significant lack of information in the Spanish-speaking news media, sadly for us who live in LA. For some of us, it felt similar to the early days of the HIV epidemic. But if the lack of information reminded us of HIV, the vaccination rollout was screaming COVID-19. Our clients came back looking for us to help navigating the appointment process. They heard there was a vaccine available, they just didn't know where or how to get it. And the fact that they also were living with HIV caused them a lot of concerns. These concerns and fears then turned into frustration and disappointment when the online process was faulty, when there was no more information available or no more appointments available for them. The lack of vaccine information for them became very, very evident in communities of color, especially when we saw extremely long lines of people who drove from really far away neighborhoods into vaccination sites located in predominantly Black and brown areas. Meanwhile, the local residents of those areas remained out of luck and with no appointments available. It was COVID-19 all over again. It seemed we did not learn the COVID lesson. Even for us, as service providers who have direct and constant communication with the health departments, we did not get appointments. Accessing the vaccine was very difficult. It wasn't until a person in one of our support groups for one of our offices tested positive that we were allowed to get the vaccine. But then finally, things started to seem and look better. A group of LGBT organizations from the LA area began taking action, and they started holding virtual halls. They started doing meetings on Facebook, Instagram live sessions, filling the empty gap that we needed. As soon as more appointments became available, we were ready to help those waiting to be registered. We were helping them to translate all this information for them. These same organizations began also holding vaccination fairs. A few weeks ago, Bienestar had its first monkeypox vaccination fair, where we also were able to provide COVID boosters, HIV testing, and referrals to PrEP. We even had mariachis for the wait time so that our community would come and have a good time. These also same LGBT organizations began partnering up with community colleges to hold in-person town halls where community members came and they finally got to ask questions. We were filling that gap. The organizations were actually taking a step forward. And as we look back at these grassroots events that started taking place, some of us started seeing HIV and COVID deja vu again, where it was left up for the organizations and community volunteers and grassroots people to fill the gaps and serve its community. Now it is my hope, the hope of my coworkers, my fellow community members, and the other partnering service providers, that this time we do learn the lesson. And that when the next virus outbreak happens, like Dimitri was mentioning, that we're ready for it. And that also the unique struggles and social disadvantages that happen in the communities that we serve that are taken into consideration so that we don't feel neglected and so that we can remain strong and healthy. Thank you.
I think you guys can do better than that. Let's give our panelists another round of applause. So in our time left, we have just enough time for one or two questions that was already submitted through the online mechanisms. The first one will actually go to our friend Joanne with the Department of Health at New York State. The question came in specifically on, can you speak to adding health equity and human rights to your job title, and how has that added access to those most impacted by monkeypox?
Thank you for that. So the addition of health equity and human rights to my title really is, it's a title. I'll be honest and say that I think over the last year or two, I've seen many people with this new title. And up until recently, when I personally also received the title, I questioned the authenticity behind it, and I questioned what it was we were trying to achieve. What I realized after working in public health, I don't want to say my age, but I'm probably going on 30 years now, is that all the work that we do is with the intention of achieving health equity, reducing health disparities, and protecting people's human rights. And we all do that in different ways. But at the end of the day, what we're trying to do, outside of those cliche words that we're all using, is work to allow individuals to live life to the fullest and have the highest quality of health. So I don't know that my title will change things because, as I've said during many introductions to the communities that I've worked in for some time, my title has changed, but my mission has not. Thank you.
Thank you. I think we'll send this to Dr. Dimitri. As a person who represents multiple communities, what are the lessons learned in which you've used in your coordinating position that others across public health can use in their response? Yes, I'm sorry, Dr. Dimitri.
Yep. Sorry, I didn't hear who it was for. So thank you for the question. I think that I can't answer it as well as Joanne just did, because I think that that's the exact answer, which is that if you bring your authenticity and who you are and what you've seen and how you connect with humans to the work, and that you live and work relentlessly to make sure that the goal is to work in spaces with love and respect to achieve the goal of optimal health, that is, I think, the best advice for folks as they enter the universe of whatever they do, public health or otherwise, and bringing that authenticity and that single-minded mission to the table.
Thank you. Julio, this one is for you. So as Dr. Merman goes back to Atlanta, as Dr. Lotto goes back to Rockville, and Dr. D head back to DC, what is the community? What do they need to know from the community explicitly? What is the message that the three of our federal partners can take back from the community?
That I think I would love for you guys to take the message that we felt neglected and that we felt unseen in the response. I work primarily with communities that are monolingual, speaking Spanish, communities that are immigrant, communities also that are HIV positive, and there seems to be a lack of information or push to help those communities. And I feel that if we get this message that we are part of this conversation, that we are also affected, you know, that we feel seen. It is easier for us as organizations, as agencies, to really take that message back and then have all the tools, have all the trainings, have all the information available and ready for them. Then I think the next outbreak, as you said, you know, could be completely different.
Thank you, thank you, thank you. So I think that some of the most important things that resonated with me throughout today's session was language justice, the importance of health literacy, and certainly ensuring that we call our elected officials and ensure that the response is supported with dollars. So you have something to do. When you get home later today and tomorrow, please, please, please pick up those phones, call your elected officials, send that letter to our folks in DC, and remember, less than 4 weeks away is Election Day. Use your power. Those who say it cannot be done are usually interrupted by those doing it, James Baldwin wrote. As we prepare to return home today, leaving empowered and fortified with something that we've learned over these seconds, minutes, hours, and days spent on this hallowed ground, remember, 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 we represent the people. We represent the people who challenged the notion that HIV was a death sentence. We represent brothers and sisters now who are remaining undetectable without daily pills. Let me say that again. From going from more than 24 pills multiple times a day to now not taking a pill and still being virally suppressed. We have the power. We must use the power. And remember, nothing about us without us is for us. Thank you, thank you, thank you for your time.
How are we doing? ¿Cómo estamos? Okay. La energía se oyó muy poca, pero bueno, los perdono. Okay, so, I just asked Damian a question. He's a young Puerto Rican man, an upcoming leader in the community, and I was curious to know how he felt after this conference. And Damian told me that, he felt that it was a great space for him to grow, that he felt he grew out of the conference, that he was able to connect to the community in ways that he hadn't done it before, right? And I don't want to put words in your mouth. So I was very pleased. I'm wondering if for many of you, this has been the same kind of feeling, right? So I'm going to let Damian maybe tell you a little more about that. And thank you again for being here and supporting Puerto Rico.
Thank you, everyone. I wanted to start by saying that as the proud Puerto Rican that I am, I hope that you got to enjoy the island. I hope that you got to, thank you can clap for that. Thank you. I hope you were able to at least skip 1 or 2 sessions only, to attend, to go to Old San Juan, to go to the beach maybe, but to also understand the complexities of the island, the contradictions of the island, and the hardships that we endure politically and also economically. And as Moises was saying, yes, this experience has been great for me, right? Because I am honored and proud to be able to host USCHA in my homeland. And I hope you were able to talk to local folks to understand how these issues also impact ending the HIV epidemic here in Puerto Rico. And USCHA, we didn't want it to be in the void, right? We also wanted to, we didn't want to avoid this conversation. We actually wanted to be the center, not only for the culture, the food, but also to highlight the issues that we endure here on the island. And I hope that USCHA was able to give you all a taste of what Puerto Rico is like. But I do have to say that this was not only an effort of NMAC, this was a collaboration with other organizations, but mostly with the host committee. I wanted to thank the host committee for those long hours, those meetings in my simisi. It might seem easy, but it takes a lot of effort to put this conference together. So thank you so much, Joey, Jose Joaquin, and everyone from the host committee.
Buenas tardes, Puerto Rico.
We would like to thank
for the federal colleagues. Please put our territories in our map data nationally. HRSA, CDC, NIH, SAMHSA, HUD and HOPWA, please.
We would like to thank, We would like to thank all of you for coming to Puerto Rico and visiting our islands. And I hope that you all had a wonderful experience here at the conference. I want to remind you that we're still receiving donations for the recovery of Fiona. You can find the link in the last newsletter of NMAC. We would like to thank Paul Kawada and the entire staff of NMAC, who've been amazing. We also want to thank Gilead and their generous support of the host committee. We want to thank our volunteers who have been amazing. So any volunteers, please stand up that are here. And obviously, this conference would not have been possible without the arduous and incredible support and work of the host committee, which is standing before you. Thank you.
Queremos darle las gracias primero a cada uno de ustedes por estar aquí, por no quitarse, como decimos en Puerto Rico, porque pese a que hubo un huracán, llegaron y nosotros pudimos hacer esta conferencia. Gracias, y acuérdense que aún pueden apoyar los esfuerzos de recuperación de Fiona. Vayan a la página de ENMAC y vean el enlace en el newsletter de cómo apoyar los esfuerzos de Fiona. Tercero, gracias a Paul Kawata, a la Junta de Directores de ENMAC y a todo el personal por apoyar, a Tara, a Shanta, a Allison, a Sonia, a Stefan, a mi hermano del alma Moisés, a Damián y a todo el equipo de ENMAC. Gracias a la farmacéutica Gilead por apoyar el comité local y apoyar a ENMAC en este gran esfuerzo. Y sobre todo gracias a nuestros voluntarios, al comité anfitrión de esta conferencia y a mi hermano del alma, quien la vida me ha traído a mi familia, que es Joey Pons. Gracias a todos y todas. No se olviden de Puerto Rico, no se olviden de la Florida. Y ahora pasamos el batón al nuevo comité, quien se encargará de USCHA 2023.
We welcome the host committee.
Testing. So we look forward to seeing you in Washington, D.C. in 2023. Safe travels home.